whoever has joined. Thanks, Dr. Lata and Dr. Ishak, for taking your time to teach our nurses regarding the end of life care and the basics of pediatric palliative care. So we have this nursing session every month, and our aim is to teach the nurses and empower them with the basics of pediatric hematology, oncology. Okay. So without wasting much time, I'll hand over to both of you. I request you both to complete the session by 4:55, and we can have the questions at the end if there are any. Over to Dr. Lata. Thank you.
Thank you, Dharani. Good evening, everyone. For those who don't, me and Dharani work in the same unit, so we don't want any formal invitation among two of us. I thank the IAP PHO chapter and the successful team behind this online nursing education, which is going on for so long. Okay, so coming to basics of pediatric palliative care. I'm not able to move my slide. Yeah, okay. So WHO defines palliative care as an approach that is improving the quality of life of patients as well as their families, those who have problems associated with life-threatening illnesses. And this is done by prevention and then by the relief of suffering, by early identification and impeccable assessment, which means a careful and an assessment which has no error in identifying the status of the child, by treating the pain and other problems such as physical, psychosocial, and spiritual. So if you want to highlight what is the main concept of palliative care is, it is not only paying importance to the patients, but as well as to the families. And it is not only to the pain, but all the other problems like physical, psychosocial, and spiritual. So generally for a common person, if you take, if they hear the word cancer, it is always associated with negativity. Similarly, when the person who are not being exposed to the concept of palliative care, when they hear the term palliation, they always think that it is almost equivalent to giving up and nothing much can be done. So I want you all to replace that image of a dried tree to be replaced with this tree, which is green, which has a lot of love and emotions, and which is treating the whole person, and it supports the family as well. And we are trying to improve the quality of life, and there is an extra layer of support. So whenever you think of palliation, think of this green tree. So palliative care is no longer considered as helping the children to die well, but it is actually helping the children and families to live well. But when the time is certain, you help them to die gently, which are actually associated with palliation. Palliation is not limited to oncology alone. So though we are trying to talk only about cancer here, the associated with palliation are life-threatening conditions and life-limiting conditions. Life-threatening conditions are those the curative treatment is feasible, but sometimes it can be unsuccessful, and the most common is the cancer. Life-limiting conditions are those where the hope of cure is almost nil. The patients are of their illness, and together both of them are considered as serious illnesses. And any serious illness is a one which carries a high risk of mortality, and it is going to affect the quality of life, and it is going to give excessive strain to the caregivers. So previously, the palliation and curative modes of treatment were two different parts. So unless and until the entire curative options were exhausted and the child was declared that no more cure is possible, they were referred to the palliation. But the recent concept is integrating the concept of palliation at the time of diagnosis so that both can go hand in hand. So there are certain few other terminologies which actually creates fear in the mind of the people when they hear about palliation, because of late there has been too much of discussion about the people are relating palliation with euthanasia. So to clear those misconceptions, withholding or withdrawing a treatment that is not medically effective is not amounting to euthanasia. So the Indian Council of Medical Research has actually given a definition that if you are going to withhold or withdraw a potentially inappropriate treatment, in a patient who is dying with a terminal illness. And if this process is going to only prolong the dying, then this cannot be considered as an intentional death. So again, in 2006, the Law Commission of India also states, it has come to the help of the physician, saying that if a patient decides that he does not want to receive medical treatment, if that is considered as illegal, then a doctor who is obeying the instructions of such competent patient to withhold or to withdraw the medical treatment is not considered to be a breach of professional duty. But in reality, the terminally ill children in India often continue to be on the disease modifying treatments or the life sustaining treatments until the hours of death, thereby causing a needless suffering both for the child as well as for the family. So it is critical that we focus on improving the survival and outcomes of those children whom we can save. Similarly, we should be able to create an infrastructure for those children whom we cannot save. So, sorry. So to make the last journey in the life more peaceful and comfortable should be our main aim. Many of you would have come across die remains in the memory of those who live on, which is actually developed by Dame Cicely Saunders. And this is the primary concept for palliation. But what are the challenges? When the family wants to do everything which is possible for the child, it becomes very difficult for the physician to tell them that we cannot cure this child. Similarly, what kind of treatment we are providing, and these treatment at some point of life can become futile, and it is only going to prolong the suffering. And especially disciplinary teams are involved, if each team is going to have its own concept, then the family might not be able to accept the point that the child is going to die. And the difficulties in palliation still continues because there are a lot of myths about the treatment modalities used in palliation. The morphine, which is one of the most commonly used drug during the palliation, is actually considered to be the root cause for majority of the myths. They generally think that morphine will cause tolerance, it will cause dependence and addiction, it can cause respiratory depression or failure. The end is going to be very near, and it is going to be very difficult to manage the side effects like vomiting and constipation. So the patients are going to be sedated, so they cannot do the day-to-day activities, and morphine can be given only by injection, or the patient should wait until the pain becomes so bad to start a morphine. The other common myths about palliative care are palliative care actually fastens the death, or it is only for those people who are dying of cancer, and people in palliation, they stop eating, and it can be provided only in a hospital. Or we, as a parent, it is our duty that we have to prevent our child at any cost from dying. And pain is considered to be a part of dying, or taking those pain medications during the palliative care can actually lead to addiction, and morphine actually increases the death. And palliative care means that the doctor has given up and there is no hope, and I am letting my family member down because he is not able to fulfill his wishes of dying at home. What is a good death? The one which is free from an avoidable distress and suffering for the patient, and it is in accordance with the wishes of the patient and caregivers, and it is consistent with the clinical, cultural, and the ethical standards. So this concept of curing sometimes, treating often, and comfort always is holding good and will hold good in the decades to come, irrespective of all our medical advancements. So we believe that the end of life deserves as much beauty, care. So what is end of life care? As defined by the National Council for Palliative Care UK, it is helping all those who has an advanced, progressive, incurable illness to live as well as possible until they die. So what is a good end of life care? So if a family is able to say finally that yes, the pain of loss is still immense, but we feel that everything that could have been done was done, and it was done by those who had knowledge, professionalism, and the person died without any pain, comfortably with those surrounded by them. So if a family is able to give such a comment at the end of the child's journey, then we should all feel immensely gratitude for having been able to provide this care. So palliative care no longer means helping children. I'm sorry, there is a repetition of this slide. Okay, so as I told, the palliative care of late is actually started at the time of disease management, and it is integrated along with the curative options. So concepts are, what are all your goals of care? Why we are trying to achieve the maximum for quality of life and comfort, and what are the reasons for limiting the interventions. So the family should actually understand that we have stopped all those interventions because it is not going to help the child, it is going to only harm the child, and it is not going to be feasible or ethical. So our main priority will only be giving comfort and improving the quality of life, and we should change the concept of doing everything, and we should also plan in such a way that the family becomes the center of decision makings. So another important term is advanced care planning. So it is actually a process where the team and the child's caregivers sit and they identify what will be the future preferences. For example, if the child is going to become sick, so what are the interventions that they want the medical team to do and not to do. So this will actually help in the future as the child is going to deteriorate. Especially we can will be receiving transfusions or not, whether they want to start on artificial hydration or nutrition, or the child needs an assisted ventilation, or in the last stages, whether a CPR needs to be given or not. So of late, this do not resuscitate term is actually being replaced by what are all the medical orders for the life sustaining treatment, MOLST. So here we will have a clearly written order saying that this is what the family wants to do and this they don't want to do. So what is end of life care? It is the care of a child and family that receive in the last few days or weeks leading up to the child's death. So the medication and interventions are considered to be appropriate based on the condition of the child. So the same intervention which was being done before, now the same is considered to be futile or fruitless. So there is an end of life uh, plan checklist. So when you declare that the child is on end of life care, make sure that all these things are being followed. The symptom management like pain, breathlessness, nausea, and vomiting are being taken care. The other stages, the other signs during the terminal illness like confusion, seizures, agitation or restlessness, excessive secretions, whether all these are being managed or not. Make sure whether the non-essential medications have inappropriate interventions like IV therapy, NG tube, gastrostomy, catheter, oxygen, and blood testing have been stopped or not. And finally, whether the resuscitation status has been agreed and recorded, and whether arrangements has been made in case of an immediate death, who are all the family members who will be contacted, and whether a bereavement support has been arranged, and whether transport arrangements are being made for the family. Place of death also plays an important role during the palliation, whether home, but the family should be made to understand that irrespective of keeping the child in the hospital under the care of the medical team is not going to help them recover from the child's illness. So usually all these children, they'll be very sick. So they'll be in the ICU with multiple IV lines, all kind of supports. Child is unconscious or it is separated from the family, or the child could be provided a gentle and a comfort care either at home or in the ward, but with the parents by the side. So why knowing all these difficulties still opt for hospital? Because they don't want the painful memories of the child's death at home, the impact that the death might have on the siblings, the social issues of neighbors and relatives accusing that they are not taking care of the child, or the child is not being taken to the hospital in spite of being very sick. The families feel that the pain and other symptom management is inadequate at home, and they feel that with the lack of the professional support from the medical team, they are not able to do any justice. All the problems that they face in the hospital Most of the times, these children will be in the ICU unless and until you have a well established palliative care department and a palliative care ward. Most of the children will be landing up in ICUs. So, where we have a strict hospital policies, which will not be waived just for the sake of this child. So, there are strict rules, no visitors, parents are not able to stay within the ICU with the child. And as per the hospital policies, the IV access need to be changed every 72 hours. CBG had to be checked every fourth hourly. But in spite of all this, the family always believe that since they are within the hospital under the care of a medical team, it gives them a false security. So, as a nurses, when you are taking care of these child during the end of life care, we have to consider that it is giving the comfort care, which is more important than following the strict policies of a sick child. So now Dr. Ishak will be taking on from here. Thank you.
Thank you, Dr. Lata, for that brief. Can be done in case of child who's having serious illness. So before starting my presentation,
Shall I
Lata,
start or you want?
Dr. Lata, are you okay to change the slides for me?
Yeah. I can do.
Yeah, thank you. So I would just like to ask our nurses any questions or any thoughts till now with what Dr. Lata has told about a child with a serious illness. Any thoughts? Any questions you have? You must have seen many children who have serious illness who are. So does it resonate with you? Do you, whenever you think about it, do you think that yes, there could have been something different that could have been done? So any thoughts from our nurses? You can also put it in the chat also. And you not feel any kind of shyness, it's okay. So the main reason why we are taking this session is for you to reflect back, thinking about whether whatever kind of care we are giving, whether they are adequate or not. So whenever we talk about palliative care, like Dr. Lata has told, I'll repeat it again. It's not only about child, but also the caregivers. There is a lot of distress that the parents and primary caregivers go through whenever their loved one is affected with a serious illness, where many a times treatment or cure is not possible. So since Dr. Lata has already talked about end of life checklist, so whenever a child is advancing towards their illness, it will be good to have this checklist visited and all the items looked into. But once they decide, okay, we'll go home or we'll be in the hospital, what can we do? So these are some principles that we can come across or we can just follow so that we provide a good end of life kind of a care or best care for the dying child. So first and foremost, you have to recognize what state the child is in, whether the child is slowly deteriorating or if the child is in a phase where they are imminently dying. Maybe they are like few days or hours away from their death, for which again a multidisciplinary team would be needed. It could involve a doctor who's trained in palliative care, a nurse who is kind of trained in palliative care or basic nursing also will do, maybe some social worker, a psychologist, etc. The other principle would be to communicate to the child and primary caregivers. Many a times we think that why should children know? Why should children know about their illness? But there have been many a times in our practice, in my practice previously, we have seen that our patients are adolescent age group or children who are very smart. They can easily read whatever expression you even have. So what best we can do is, if a child is asking you what is happening to me, they are asking because they trust you. So in that situation, don't lie to them, just listen to them. And if you're not in a position to explain them the things, just tell, okay, give me some time, I'll speak to the doctor or assigned staff and I'll get back to you. Try to communicate that fact to your higher people so that you can start to communicate about child's worries and fears. At least some communication can be done, definitely. And whenever we say communication, try to be at the level of the child. Try to speak in honest terms. Don't try to lie to them. They'll easily catch it. If they're asking you about their health and all, it means that they're not getting that information from someone else. So when they trust you, try to at least hold that trust. Don't break that trust by kind of lying to them or anything. And also giving adequate information to caregivers is very important. Few patients we have seen at times, even though we feel we have communicated that the child is not doing well, caregivers at times are not in the mental space to understand. So try to ask them back what they understood. So that is known as to ask, tell, ask. So you have to tell them few information, ask them what they understood. That way it will be easier to communicate. Also, always try to be that person who can give that opportunity for children and caregivers to discuss. We had some adolescent children who wanted to discuss about their disease with their parents, but they were not able to. So you can also be providing that opportunity by speaking to parents, saying that child has some kind of worries and fears. He or she would want to talk to you about it. So try to be that person who facilitates that kind of discussion. The other principle is to give proper prescription so that whenever they go home, they have home or home, like anywhere, they need to have adequate medication so that they feel empowered that they can take care of the child at home as well. Because as Dr. Lata said, many a times there's a false security. They think that, okay, we are in hospital, everything will be fine. But if we empower the family members saying that we can take care of the child at home also, if they wish to, these kind of things really help them in empowering, such as giving them medication, such as telling them what to look for, what kind of symptoms to look for, etc. The next would be review of clinical interventions, whether a particular thing that we are doing is helpful or not. It could be blood transfusions, it could be blood investigations, etc. So try to review, are we doing something to relieve the suffering? It could be pain, it could be breathlessness, etc. of the child, or are we just doing it for the sake of it? We can't do it in case if the child is not going to get help or any clinical benefit from it. So we need to review it. Next slide. The next principle would be to review hydration needs. Many a times, patients, attenders feel that, okay, he's not eating, let's put IV cannula. So try to review and tell them that as the child progresses, they might not require so much of hydration also. If there is a need for hydration, please provide it, provide the information and provide how to hydrate them. It could be by just checking whether they're having basic amount of hydration or not. For example, in a child who's like 15-20 kilos, even giving like 500 to 700 ml of water would be sufficed. The child need not take a lot of feeds or water during the end of life. Then again, connected to it, review of nutrition, the amount of food he or she would take would slowly decrease because the various systems are coming down. The amount of energy to maintain the different systems is also decreasing. So try to review that and also tell the family members if the child is not eating enough. We need not try to force feed. Try to give them in small quantities as and when the child asks. And the next thing would be to completely explain the care of plan. The care of plan normally for a child who's imminently dying or dying would be to provide good comfort care in, in means of providing good symptom managements. It also mainly requires giving good support throughout. And then again, when they are going back to their home or in the hospital, try to reassess periodically. It could be reassessing the symptoms or reassessing any kind of condition that is further deteriorating. And finally, dignified care after death. I have worked in a government hospital where many times, whenever there was death, the child was just left alone like that without like covering the child or kind of removing the tubes immediately. So that kind of thing we shouldn't do. We need to respect the child's body even after their death. Try to be gentle with them. Try to cover the child if they are exposed, etc. Next slide. So, what are the objectives? The objectives of end of life would be to keep the child as comfortable as possible, whatever state he or she may be. And also, the main thing would be to support the family throughout and also post the death of the child by doing some amount of bereavement support. By bereavement support, what we mean is to inquire what and how they are coping. Even a simple phone call can help. Just trying to ask how they are coping from the death of their loved one, or it could be how they are going about their days or not. What kind of thoughts they're getting of the child? Are they thoughts of distress, or are there some good memories that they are able to recollect, etc. Next slide. So, whenever we talk about end of life, one main aspect is also about taking care of physical symptoms. How do we control symptoms during the last few days to last few hours, maybe last 48 hours? So, there are some symptoms I'll be coming like dealing today. One is one major symptom that we see according to a adult kind of research. It is told that around 70 to 80% of patients have severe pain during their last stages. Similarly, for children also, many a times if you're talking about cancer, uh, half of them do have pain during the last few days of their life. The other symptom is breathlessness. Third one is urinary dysfunction, where you can think about urinary retention or incontinence that can happen, constipation, nausea and vomiting, as well as death rattle. Next slide. So again, pain, like we told, around 70 to 75% of the children during their end of life, during their imminently dying stage, the one which we call last few days to few hours, they have severe pain, moderate to severe pain. Try to remember the principles of pain management. One main thing that nurses and healthcare professionals can do is do a proper assessment of pain using pain scales. You must be seeing in your files one Baker scale where you are having faces of various expressions. Try to ask the child if they are communicating, or if try to even tell the parent to inquire if there is pain, because based on that you can give pain medication. And morphine is the drug of choice for severe pain. So never try to be scared of telling that you have to take morphine whenever there is severe pain. Try to correct the correctable. If there is any kind of wound that can be debrided, maybe you can clear that. Maybe you can provide some nursing care for that. If there is pain because of some kind of pressure source, if you have some particular sources of pain, try to decrease that. Then the other thing could be giving pain medication through the mouth. If they're not able to take through the mouth, thinking of giving parenterally. One thing which we need to remember is never suggest IM injections for any patient who is going closer to death or in the hospital as well. There are other better routes you can give through subcutaneous route or through IV route. And if there is no pain also, try to give them some medication anticipatorily, thinking that there could be pain later on. Next slide. The next symptoms is breathlessness. It could be reversible, it could be irreversible, it could be corrected or not corrected also. But one major thing what we can think of is there are some medications that we can give. For example, you can use morphine for breathlessness. Many people feel okay, morphine can cause respiratory depression and it can lead to different symptoms. But what morphine does is it makes the child less aware of his or her breathlessness. They can decrease that hyperventilation, anxiety cycle. They can break the cycle. And when it is used with benzodiazepines such as lorazepam, it is really beneficial and helpful. And try to explain the family members about the role of oxygen also. Many people feel if there is breathlessness, put oxygen. But there are many other ways by which you can decrease breathlessness. You can tell them to breathe through the nose, leave through the mouth slowly by pursed lip breathing, such as you'll breathe and you'll slowly release it. That is one way. The other would be wiping the face of the child, of the patient, with wet cloth. It could be by just fanning the face also. These are some non-pharmacological things that we can tell them to do. And we also feel supported if they have been given a role to actually play during the taking care of the child's symptom management. Next slide. So these are the medications. I won't go into the dosages particularly, but morphine can be started with so morphine can be started with a small dose and slowly titrated as per the need of the child. And like we told, morphine along with benzodiazepines have a added effect. So if with morphine the child is comfortable, you can just use that. In case of terminal breathlessness, suppose breathlessness is very terminal, patient or the child is feeling severely distressed, you can think of giving palliative sedation. Palliative sedation here is to only provide comfort from the symptom. Many people feel if we give palliative sedation, child won't get up, won't eat and all. If the symptom is intractable, the symptom is causing a huge amount of suffering, then the child won't be even in a position to take any feeds or anything. So giving palliative sedation to at least like decrease the suffering is the choice which we need to take and need to explain also. Next slide. For palliative sedation, again, you can use morphine, haloperidol, as well as midazolam, etc. So what does morphine do? It will decrease the respiratory drive. It decreases anxiety. And if the patient is already on morphine, try to increase the dose, or you can actually increase the frequency of dosing also. And whenever you give a morphine dose, you need not wait for 4 hours. You can give in between also. SOS doses you can give every 1 to 2 hourly if it is oral. If it is injectable form, you can give every 15 to 30 minutes, depending on the kind of symptom you're dealing with. If it is intractable symptoms, you can give repeatedly. So our dear nurses, don't be feared if a doctor just writes a prescription saying SOS to give this particular way. You please follow it. Don't be scared that, okay, we can't give so often. Next slide. So we have one comment also, we'll take that. And coming to urinary dysfunction, again, if the child is conscious, if you feel that it will be helpful to relieve the retention by means of catheterization, intermittent, try to do that. If the child is unconscious, leading to retention, the best possible thing would be to keep them catheterized. Next slide. Nausea and vomiting is one more main symptom. You try to identify and treat the cause. If there is some kind of obstruction, then you need to think about what do you do for intestinal obstruction. For various causes, if it is drug induced, you will give haloperidol. If it is metabolic, you can think of haloperidol as well. If there is gastric irritation or brain metastasis, maybe you can try using dexamethasone for brain metastasis. Next slide. For gastric irritation, you can simply use antacid as well. The other symptom is death rattle. One main thing, it is kind of a strong predictor of death. Many times around 75% of the patient dies within 48 hours of its onset. So what is death rattle? It is collection whenever there is collection of some respiratory secretion. Whenever the child breathes, there is a hoarse kind of a sound. And that sound is little scary for even staff, as well as very distressing to family members because they feel that the child is very distressed by this. Try to reassure the family members that the child is not choking, and this is a secretion mostly that wouldn't cause severe distress to the child. Next slide. The main plan would be to change in position, usage of gentle suctioning. Never do suctioning that is very deep. Don't go deep till the uvula or furthermore. That will lead to the child getting gagged. If you have to remove secretion, you can do it through the nose near the lower part, or just gently near the buccal region, or even try to turn the child on one side. Even if you're going for some suctioning through the tube, try to keep the pressure adequate. Don't keep high pressures. Many a times, pressures of 200, 300 are also. Never do that. Just try to change position, try to do it oral manual suction, and you can use some medications as well if you feel there is huge amount of secretions. These are the various medications. Next slide. And the main aim is to reduce the distress whenever we come across emergencies. They are mostly irreversible. So if there are any emergencies that come in the last 48 hours, when we talk about emergencies, these are not pain or any kind of respiratory distress, etc. But these are actual main symptoms such as convulsions, agitation, hemorrhage, or acute stridor due to blockage of airway. Next slide. I'll just go a little bit fast here in view of time. So in acute stridor, there are some pharmacological things that you can do. If there is clear-cut blockage that you are able to remove, try to remove, or you can use some kind of anti-edema measures. Or if the stridor is terminal, you can think of sedation of the child because you don't want the child to have distress. Next slide. Convulsions. Always continue anticonvulsants. If a child is not able to take orally, try to ask the family members to give it through injectable form. Injections can be given in subcutaneous route also. You need not always have IV route. If there is convulsions, you tell them to keep the child flat on one side, you turn them on one side. Okay, don't give any sharp objects. Give midazolam subcutaneous or through intranasal midazolam. Rectal diazepam is also an option. But if you are anticipating convulsions, if a child is having brain tumor or any previous history of convulsions, there are chances the child can convulse again. Try to give a prescription for the intranasal midazolam. Next slide. Restlessness. Try to identify the cause. What is the cause of restlessness? If restlessness is because of urinary retention, constipation, because of pain, some children are not able to tell if they are in pain. So try to treat that cause so that agitation is reversed. Next slide. There are some medications also. For example, if agitation is looking like delirium, then these are the various medications that you can use. You can mainly use haloperidol that comes in different formulation. Again, if you have to give haloperidol in parenteral route, you can give subcutaneously also. And delirium, there are multiple scales. You can just Google scale for delirium in children. There is something known as CAPD, Cornell Assessment of Pediatric Delirium, CAPD. Based on that, you can know whether the child is in delirium or not. If the child is in delirium, please provide appropriate pharmacological and non-pharmacological measures. Next slide. The other symptom, the other emergency basically is hemorrhage. Suppose if a child is coming with severe big tumor in their leg, around femur region or shoulder region, etc., there is chances of huge amount of capillaries and vessels that can get exposed and that can lead to bleeding. In 60 to 100%, there could be death. And what we need to use here is usage of opioid and benzodiazepine to make the child relaxed and sedated. You want to sedate the child so that the child doesn't become conscious of the fact that he or she is bleeding huge amount of blood. And try to protect the airway. If there is bleeding in the mouth, try to just the one side of their body and use dark cloths so that the family members are not scared because of the huge amount of blood loss. Reassurance that you are there to take care of the child. If they are at home, try to reassure them on phone. Try to give adequate medications also. Next slide. Again, now after coming to emergencies, just let's briefly talk about what general nursing care we can do. Whether the child is in end of life, imminently dying, they need some general nursing care. That could be mouth care, taking care of their mouth, whether they are having any kind of good hygiene or not, giving good skin care, trying to avoid any bed sores, pressure sores. Assume that the child can hear you. Keep communicating in a simpler way. Whenever you're doing something, try to seek permission. Tell that, okay, I'm going to do this. I'm going to turn your body. I'm going to clean you. That kind of thing is very important. Health and emotional needs of the caregivers can be dealt by our nursing staff as well. Try to speak to them. Try to just assess if they have some distress that they would want to speak out or vent out. Try to simply ask, is there something you would want to talk about? If you're not having time, try to delegate it to a healthcare professional who is able to give that time. It could be a social worker, psychologist, etc. Encourage presence of close family members around the child, and try to also tell that physical touch is something that we can do to the child, because child will be able to perceive. Next slide. Whenever you're doing general nursing care, have a close watch on the various parameters. The parameters will decrease. For example, blood pressure will be usually low. It is totally common. Don't get very alarmed. Try to tell to the physician or the doctor. That will better help in communicating that whether the child is moving closer to their death or not. Pulse, again, it might be usually increased, but keep in mind, even pain or temperature, rise temperature can lead to increased pulse. So if the child is in pain, try to assess it and try to give the adequate medication. Respirations, temperature, again, it could be decreased or increased. Next slide. Now, again, like I told, whenever there is intractable symptom, where still it is not coming down, think of palliative sedation, or you can even suggest to your physician to try palliative sedation in this child. Next slide. Again, the sole purpose is to reduce distress. Never think whenever we are doing palliative sedation, you are trying to lead to the death of the child. It is not so. If the symptoms are very intractable, if we don't take care of it, that itself can lead to the death of the child. So the sole purpose here is to reduce distress. When all measures have failed, when you have given all the necessary medications. So the medications which you can use for palliative sedation are midazolam, haloperidol, as well as morphine. Few people use fentanyl, but the most commonly used drugs easily available are midazolam, haloperidol, and morphine. Next slide. And you keep on reviewing the medications. Always see if these adequate medications are there with the child. In your list, definitely there should be pain medication, antiemetic, anti-anxiolytic, uh, anxiolytic, as well as antipsychotics, as well as anticonvulsants. If oral is not possible, try to tell them various routes. For example, for anticonvulsants, you can talk about intranasal route or rectal route. You can talk about giving subcutaneous route. Tell them never to give any injection IM. Okay, rather give subcutaneous rather than giving IM. Explain to caregivers why you are withholding some medications, because as the body is slowly cutting down on the various systems, the child wouldn't require to have all the medications, such as antibiotics, such as giving medication for various other symptoms apart from what we have mentioned. Next slide. In the guidelines, foremost things which we need to remember is have proper, honest communication. Don't give them false hopes that everything will be fine. If a parent or loved one, or if the child's loved one is crying, don't cry. That is one thing that is very bad. Let them cry. Just be there beside if you are able to be there. Try to just ask if there is something that is bothering them that they would want to talk to. Try to accurately document. It could be documentation of the scales, documentation of medicines you are giving. After that, what kind of care you are going to give? Is it an ambulance you're going to send to their hometown, or are you going to kind of wrap the baby properly or keep the baby in the mortuary? All these things need to be known prior itself. Bereavement care, like I told you, trying to do a call to just know how they're doing comes a long way. And a review of the whole care process is also needed. Next slide. Again, in different setting, like Dr. Lata told, some want to be at home, some want to be at hospital. So in different setting, the main principles would be those 10 itself. In the hospital, try to allow attenders to be beside the child. Even in case of ICU, try to at least bring the main caregivers, it could be parents or grandparents, to be beside the child. So these are the some things that we can do in case of hospital setting also. Next slide. So this is one image where you can see uh, the doctor is taking care of the patient at their home. Next slide. At home, the main reasons and the main things that we need to do is empower the family. Try to tell them these are the simple, say, few symptoms that can come that they need to identify and give adequate drugs. Suppose if there is death of the child, what kind of care they have to give. Give them proper 24/7 helpline phone numbers so that they can contact you if there is any kind of crisis. Nurses, volunteers can come along and provide that empowerment to the patient, and also palliative care at home if you can give, that would be great. Also try to talk to the local hospital doctor, or it could be an RMP also. Try to liaison with them. Try to explain them what the child is suffering from and what all various things that we can do, because we don't want them to again take them to their hospital, give IV fluids, give antibiotics, give put on ventilator, etc. Try to also get in touch with the nearest hospital as well. Next slide. And these are some ethical approaches that we need to remember, not going into detail, but what we need to remember is always try to know what the patient and family wants. Respect patient's wishes. Don't push our agenda of like, okay, we want this to be done. If we have some recommendation, try to explain what are the reasons why you're giving this recommendation. And we need to fairly allocate societal resources. Try to avoid futile treatment, and if there is any treatment that is not going to help the child, try to withdraw it. Next slide. And these are the various things, not going into detail again. Try to manage and assess the symptoms properly. Anticipatory prescription should be given. Also, if there are refractory symptoms, think about palliative sedation and always review. Just because the child is dying doesn't mean that we don't review them regularly. Try to review them. Next slide. And again, care after death. One most important thing is try to give privacy and space to the family to grieve. Don't send them away immediately. Lay the body in a very culturally appropriate manner, and timely giving of certification is very helpful also. Next slide. And these are the few small checklists that we can do. Next slide. So main thing I would conclude by saying that we all can empower the family, but we need to be trained a bit. Try to get that kind of training whenever possible. Try to give some amount of communication to the family in an honest way. Try to not use medical jargon. Try to assess, try to manage the child and family's distress. Show confidence. You will be able to do, you can do this. This is not something very high level. It only requires some amount of empathy from your side. I know it is quite difficult at times to see a dying child, but we are always there to help you out, and try to form a team of support whenever you're dealing with children who are closer to that death, or children who are having serious illnesses. Next slide. These are some references where you can get some medical information about palliative care. These are some books. Next slide. And thank you all for attending. With this policy statement, I would end slides today. Palliative care is a human right. It's not that you're doing as a favor or anything. Palliative care is a human right, and that every individual has to or has a right to good, peaceful, dignified death. So never feel that, okay, why do we need palliative care? If that way, if you're thinking, then you are mistaken. palliative care is very much needed in every patient who is having serious illness. Just think about if we are suffering from serious illness, wouldn't we want support? We would want that physical, psychosocial, emotional, spiritual support, right? So always, if there is a possibility of you coming across someone with serious illness, try to find resources which can provide palliative care to them, or you get trained, you provide that care to them. So with this, I end my presentation. Thank you. We have 5 minutes.
Thank you. Yeah, thanks a lot, Dr. Ishak and Dr. Lata. I think you have made such a difficult topic so comprehensive and crisp to understand. So yeah, I don't see any questions in the chat box, but I had a question myself.
Yeah.
So
Dr. Lata, would you like to take that in your
yeah,
setup? I can also add some things.
No, I'm not able to see it. Wait. Yeah.
How
so I was
practical
asking
is it?
how, yeah, in our setting to discuss the place of death of child with the parents.
Yeah, in the past few cases that I had managed, so we were able to actually talk to the parents, and three of them we had actually succeeded. The child died in the home itself. Maybe it was possible because the parents have understood the concept. Because every time you try to tell, but if the parents are not able to accept it, finally we land up in doing what we are not actually supposed to do. In this case, all the three parents were. I mean, they were in line with our own concepts, so we were able to do it. Yes, in these three cases, it was possible, but maybe it's only a smallest number of people that I have handled in the past few months. So that's all.
I would just add one more point to that, what Dr. Lata said. Even three patients is a good number to start with. Regarding how practical it is in our setting to discuss place of death, each and every patient who is having serious illness or having going closer to the death have to be discussed. This has to be discussed with the family. There is no other way around. Whether we are able to succeed them or empower them for them to go to their home and die, that is again a different thing. But place of death discussion needs to be done, and why are we even discussing it needs to be explained, like what Dr. Lata is doing. So in any setting, whether it is a private setting, government setup, or a semi-private, uh, that is something very important. Uh, the place of death.
It is very difficult because the last patient that we dealt was from Vellore, progressive neuroblastoma. So the father would call every now and then saying, Doctor, he's not taking anything. So can we take him to the hospital? Can we put an IV line? Then I'll say, so putting an IV line is going to be difficult because you yourself have told IV access is difficult. So why do you want to put an IV line? Then he'll remain silent for some time. Okay, doctor, I accept. So we don't want IV line. So it needs some reinforcement from our side, because every time the parents ask, we cannot give up what they are telling. So we have to be firm saying that this is not going to help your child. So your intentions is right, but the path that you're taking is actually not helping it. So please don't do it. So all the three families, they have understood, and they were able to do it. But we might not be successful in every case. We similarly had one more case, which Dharmi also knows, child with brainstem glioma. The child died in the hospital, was there for 6 weeks in the ICU, intubated. So it happens. You see both the families. So whenever we start talking, the first line the family will say, Doctor, we understand everything, we know, but leave aside the medicine, leave aside the science. I feel that my child will come out. So let us not talk about that. So with this attitude, we have not been able to do anything to make the death peaceful or dignified or less suffering. No, we were not able to do it. But the only concept is the parents would not have felt guilty, and the 6 weeks, the positive hope that they had might have actually helped them to overcome this process. Because every day you meet them, the mother is so smiling. She will always start with a thank you message saying that, Doctor, you have all been taking so care. We are very glad that we have landed up here. So you can never say a word against that family. I think that is the thing which actually helped them. Otherwise, they would have felt it very difficult for spending 6 weeks in an ICU with a child who has been declared to be, I mean, with brainstem dysfunction. Yes.
Yeah. Adding one point to that, many a times, like Dr. Lata has told, parents or caregivers have this thing that are they doing enough or not? So many a times they would call and ask the same question. So we as physicians, as Dr. Lata has told, have to be very particular in our communication to them. Shouldn't be like, okay, maybe we'll give IV fluid, let's bring. So that shouldn't be. It shouldn't be too like, we shouldn't change the goalpost. There are some patients, attenders who would want to be in the hospital, and it is totally fine. But that doesn't stop us from communicating the fact that, okay, these are the things. If you want care to be at the hospital, we will do that. But like Dr. Lata has told, it all comes down to whether the parent is feeling that they're doing enough for their child or not. And in whatever state, we are here to support them. So thanks for sharing that, Dr. Lata. It must have been very difficult for the team and
So true. Finally, I agree that it's only the fact that, whatever you decide, I'll be there to support. That's the message that should reach the family.
yes.
So instead of what I say you do and then I support should not be the message.
Yes.
So I think it's a very hard thing for you, I mean, those who are counseling, to get it across to the parents and make them believe, make them develop the trust on us, and then provide the care. It needs a very long sustenance and a lot of efforts. I do agree. We have Dr. Siaram here. He's a pediatric hematologist at AIMS Jodhpur. So Siaram, do you want to add anything or suggestion or comment, question?
Dr. Siaram, your voice is not audible.
Siaram?
He's still muted.
Siaram, you're muted. Do you want to add anything?
But thanks to Dr. Dharni and Dr. Lata for giving me this opportunity to discuss about end of life with you. Maybe
I
we can
think
do
I've
some
lost
sessions
Dr.
on
Siaram
communication
probably.
also for our nurses. Some basic communication, if we can do, it will be helpful.
Yes, surely. So we will definitely have these sessions. Basically, this is a once-a-month session that we have for the nurses. We are rotating the topics in pediatric hematology, oncology, and palliative care. So we'll probably frame the sessions for 1 year. That's what we are planning to, and we're trying to have at least 3 to 4 sessions on communication, empowerment, palliative care, end of life care. So we'll try to contact you often. Thanks a lot, Lata and Ishak, for taking your time and giving us the insights. Thanks all the delegates who have participated. And I now hand over the session back to Manisha. Thank you.
Thank you, everyone. Thank you for the wonderful session today. And I have shared the feedback link in the chat box and request all the participants to just share your feedback for the session. Thank you, everyone. With this, I think we can close this session. So we will meet you soon. Okay, bye-bye. Thank you.
Thank you.